Greetings and a warm welcome to all the dignitaries present here. I am Asya from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clernet serves as the digital partner for this event, hosted by the Indian Society of Pediatric Neurosurgery. The focus of today's webinar is Pediatric Neuro-Oncology Spine. So let's begin today's session, for which I would like to invite Dr. Suhas Udaykumaran sir. Kindly proceed with your talk, sir. Over to you.
Thank you, Asya. And good evening, all those who have joined. So today is a part of our continuation of our neuro-oncology sessions, and today's part of the spinal neuro-oncology. And as a continuation of our last class, we have intramedullary as the theme today. For that, my colleagues from AIIMS, Dr. Sachin Borkar, and Dr. Harsh Deora from NIMHANS will be talking on the intramedullary spinal cord tumors. For all those who have not attended these classes, these virtual classes happen every last Sunday of every month. So I'll hand over to Sachin to continue with the rest of the talk. Dr. Sachin, proceed. Thank you.
Thank you so much, Dr. Suhas and the Indian Society of Pediatric Neurosurgery for this opportunity. Many of you may have attended the last lecture, and it was on the overview of the spinal cord tumors. Along with, we discussed in that webinar about the intradural extramedullary spine tumors. So is my screen visible?
No, yet to.
Not yet.
Yes, sharing, happening.
So this time we'll be discussing about the intramedullary spinal cord tumors. In the last webinar, we already discussed how the clinical presentation of the tumors vary depending on its location within the spinal cord. If it's an intradural extramedullary tumor, the compression will be from outside in, compared to an intramedullary tumor in which the compression is from within outside. So based on that, the clinical presentation will vary. If you consider this cross-section of the spinal cord, the intramedullary tumor arises from in and around this central canal, compared to an extramedullary tumor, which is either from the nerve roots, which is basically peripherally placed. So any compression by a peripherally placed tumor will affect the corticospinal tract and the topographic arrangement of the fibers arranged, that the sacral fibers are lateral and the cervical are medial. So in that way, the lower limbs will be affected first in those tumors, and the bladder bowel involvement will be quite late in intradural extramedullary compared to an intramedullary tumor, which is around the central canal in which the autonomic fibers are there. So early bladder bowel involvement and more involvement of the upper limb compared to lower limb, because the cervical fibers will be affected first in intramedullary tumor. So all these things we already discussed. This was just a brush up to have that. And the most common intradural extramedullary regions which we encounter in clinical practice are the neurofibroma and the meningioma, and the intramedullary tumors which we usually encounter are ependymomas and astrocytomas, and maybe hemangioblastoma in a small percentage of cases. Dr. Harsh will talk more on that, but just I'm sharing one of his slide in which, compared to the brain, in which glioblastomas are more common among gliomas. In spine, the glioblastomas are quite rare. The predominant tumor, intramedullary tumor in spine is actually ependymoma, which constitute almost 60 to 80% of the spinal glioma. And the others are the astrocytomas, most of them the grade 1 pilocytic astrocytoma. So the predominant intramedullary tumor which you will encounter in your clinical practice will be ependymomas and astrocytomas. most likely grade 1 pilocytic, and grade 2 or 3 maybe rarely, but this will be the usual distribution. Okay, so we will go back to the surgical technique. Surgical technique is important because these are intrinsic spinal cord tumors. So you have to be extremely careful with your surgical technique because any deficit can be devastating for the patient. So you should understand the anatomy quite well, how the layers of the meninges are stacked up, and how to work between the by exploiting the arachnoid layers and everything. So as you can see, this is a simplification of what we were discussing. If the tumor is arising from the central canal, maybe the ependymal cells of the central canal, then it's an ependymoma, which is quite central to the substance of the cord. Basically, it expands the central canal like this. So there is a thin ream of cord tissue all around, compared to an astrocytoma, which can arise from any part of the glial tissue. It can be eccentric, and something like a hemangioblastoma, which is subpial, so just below the pia. It's there. It is actually projecting through the surface of the cord. So this is the difference between this. Radiologically also, you can differentiate among these tumors a bit. There are some radiological findings which are very particular, like an arachnoid cap or a solid cystic tumor at the end is usually suggestive of ependymoma. Pilocytic astrocytoma are more homogeneous sort of tumors, less chances of cyst formation, less chances of syrinx formation. Ependymoma and hemangioblastoma are known for syrinx formation, and this hemangioblastoma are extremely vascular. There can be vascular flow voids in addition to the contrast enhancement of the tumor. So as you can see, this is a completely intrinsic, most likely an ependymoma. And compared to this is the subpial. This is actually the cervicomedullary junction. So it is at the maybe this medulla and C1 junction. This is a intensely enhancing tumor, which is a hemangioblastoma. So the position for all these cases is standard prone, depending on the location. Pediatrics, you have to be extremely careful about using the pediatric pins, especially if you're using it in the cervical region, because at times the thickness of the skull is quite less. So, or you can take them on a horseshoe. Neuromonitoring will be dealt by Dr. Hirsch in the next talk, but it's preferable to use neuromonitoring for all these cases. The standard posterior midline exposure, either you do a laminectomy or a laminoplasty. In children, especially if you have a long segment tumor, it's preferable to do a laminoplasty or osteoplastic laminotomy. Just open it like a complete en bloc, elevate it, and then replace it back, because the chances of post-laminectomy kyphosis are more if it's a long segment laminectomy. And depending on your availability, you can either use the drill or ultrasonic scalpel to do laminotomy. Drill causes a bit of bone loss. Ultrasonic scalpel is more controlled and obviously causes less bone loss. So if you replace it back, there is chances that it can fuse once again because the bone gap is less. So this is how the exposure should look like. Complete exposure, including the medial aspect of the lateral mass. This is the cervical region. And you can then do the laminotomy at the lamina facet junction. So this is the lamina facet junction, which way we have marked, and using this ultrasonic scalpel, you can do a laminotomy at that junction. And just to tell you how a drill is different, it causes a bigger trough compared to what we done on the other side. So it's better to use an ultrasonic scalpel if available. Then the most important thing in any intramedullary tumor, at times there you will find a normal cord and the tumor is completely intrinsic. You do not know from where to enter because each of this is an important issue. You may be going through the posterior columns, or you can damage them if you're not careful. So there are different ways to identify the true midline in an intramedullary spinal cord tumor. So there is always a posterior median sulcus. At times it's very difficult to find out because it may be distorted because of the underlying tumor. But if it's available, usually this is the posterior median sulcus in which the vessels dip in, and it's almost equidistant from these roots. So that is one way of finding. If you can find out, you have to open this sulcus. The other more reproducible way is to use this root entry zones on either side, and approximate middle point of that is usually the posterior median sulcus. This is a more reproducible way of identifying the midline. And then there are other things like small veins exiting from the posterior median sulcus, and small crossing vessels like this can be coagulated if need be. But the most important is to identify the midline using the dorsal root entry zone. So this is what I'm going to say, the equidistant from both the root entry zones. Then there are various ways how to open this arachnoid and the pia, and it's better to use a very thin knife, maybe a diamond knife or a number 11 or 15 surgical blade to open this arachnoid and pia, and use a fine flat microdissector to work between the posterior columns. So it comes with experience, but it's really possible so that there will be minimum damage to the normal cord. So, and always use a traumatic fine suction tip. Do not indiscriminately coagulate. You can put some Surgicel if there is some bleeding, because all these are normal tissue. Unless you are on the tumor, probably unnecessary coagulation is not needed. If it's a small twig which is bleeding, you can coagulate, but unnecessary charring it is not advisable. Then you can take some pile sutures. Once you open this posterior midline, the posterior columns fall back on the tumor. So to expose the tumor completely, it may be advisable to take pile stitches to keep this myelotomy open. I'll show it in the video in some time. And then you do an intratumoral debulking using CUSA. In ependymoma, it is easier to identify the tumor cord interface because there is a good plane between the tumor and the Deora and the cord parenchyma. But you have to be careful about the ventral dissection because ventrally there is corticospinal tract, and if you are extra aggressive or not careful, then you can damage the normal vascular supply of the cord. So you have to be careful. So at times there can be small vessels which are coming within the tumor, which is carefully divided by gentle coagulation and sharp dissection. So this is one case of ependymoma. You can see a cervicomedullary, cervicodorsal tumor, completely intrinsic, good contrast enhancement. And this one is a 7-year-old child having a long segment intramedullary spinal cord tumor. We thought it's to be an ependymoma. There is some arachnoid cap here. The edema extends well beyond. That is not edema, actually, that's the syrinx. So many points in favor of an ependymoma. And this was what was done, laminoplasty and excision of the tumor. You can note that the biopsy turned out to be pilocytic, so there can be surprises. So the plane is not very great ventrally, so we may have left a tiny bit of tumor ventrally. This is the immediate post-op scan, so there is some air and blood, but all in all, a good excision, and the patient is doing well on follow. So another case, the hemangioblastoma, as we have seen that this is a subpile tumor, intensely contrast enhancing. We dealt it by basically these tumors, you cannot enter these tumors, you have to remove them en bloc. So if it's a small tumor, it's not a problem. But if it's a large tumor, which I'll show a case in which it was quite big, you have to be extremely careful you're removing it en bloc. So I'll just take you to the hemangioma PPT in a bit detail because these are tricky tumors. So this is what is an
Sachin, your video is,
hemangioblastoma.
Sachin, your video is not seen. Huh? Video screen is not seen.
Sir, I think you are sharing the PPT. You need to share the desktop.
I'm just a
Yeah.
minute. I'll share again.
Yes,
Yeah.
sir.
I think there was some pause, sharing was paused, something like that. So I'll just
Yeah.
Okay, sir.
For the residents, if you have any questions, you might raise your hands and you might be able to, we might be able to include you in the audio. So please.
Okay, now it's visible?
Yes,
Yes, sir, yes, sir.
Go ahead.
Yeah. So this is what I was telling you, the flow voids in addition to the tumor. So this is a C1 to C3, C4 tumor with a lot of flow voids. So that should alert you to the possibility of hemangioblastoma. There's intense contrast enhancement and a lot of flow voids. So you have to be careful in dealing with these cases because they are subpile, but you cannot debulk them like you do an ependymoma and astrocytoma. You need to be extremely careful. They are very vascular tumor that can be found throughout the central nervous system, but only 2% of the spinal cord tumors are hemangioblastoma. And obviously, even if it's a small tumor, it can cause a hollow cord syrinx. So we have reported one case in which there was some contrast enhancement in the conus, but the entire cord was studded with syringomyelia. So these are notorious for causing syringomyelia. And obviously, it is associated, as with cranial hemangioblastoma, with the VHL syndrome. And they are more occur more commonly as isolated lesions, spinal hemangioblastoma, compared to the multiple cerebellar and retinal lesions as a part of VHL. And location is most common is cervical, followed by thoracic and lumbosacral. And all these things can happen. And once we take to the videos, you will understand how they have to be tackled. So we'll start with the surgical technique of intramedullary. Again, I think it is paused once again.
Yes, sir. I think
Yeah,
it's
just a
good.
minute, just a minute. I think once switching in between the presentation, then it gets paused. So I'll share it once again.
Yeah. Yeah. Back.
No, that's back.
Yeah.
I want to share the
Oh,
video.
the video. Yeah.
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 Is the video. Now you can see
Yes,
this?
yes, yes,
Yes,
yes.
sir.
Yeah. So this is probably a different case in which I showed the laminotomy. This is a long segment tumor. And again, we are doing the same thing, exposing subperiosteally and then using this ultrasonic scalpel. Under magnification, you are doing this laminotomy at the lamina facet junction. So since this is regarding the surgical technique, it's a bit of not very much edited video. So you will get to know all the steps in this video. So extremely careful, lot of irrigation. There is actually inbuilt in CUSA. So you do not need to worry about and do this full thickness. There will be loss of resistance. The same thing is repeated on the other side as well. So at the upper and the lower end, you may have to remove the, at least on one end, you may have to remove the interspinous and the supraspinous ligament because you wish to open it like a book. So I usually hinge it on either a superior or the inferior side, keeping the, so that when you want to suture it back, you will have to just do it on one side rather than en bloc removing it and keeping it outside. We can just do a flap sort of thing. That's a laminotomy sort of thing. So this is how since it's at multiple level, it takes a bit of time, but this is worth the efforts because the bone loss you can see is actually it's a thin cut only, and it will fall back once you are done with the case. It will be quite in opposition, both the edges of the bone, and there is chance that it can fuse well. So even if there is recurrence later on, and if you want to go in again, you have the cover of this bone, which may not be there in case you are doing laminectomy. So always in spine or any oncology, you should try to restore your anatomy as much as possible because these tumors can recur. And whenever you want to do a revision surgery, having the bony cover is always advisable. Desirable, obviously. And now you can see removing the interspinous ligament on one side and detaching it from the upper end. And since you have did it on both the sides, you can just we have elevated it like a book. So it's not a very much edited video. So you will see some blood, which is usually not seen in super edited videos, but that's the part of the game. And once you have achieved that hemostasis, then you open the Deora, initially with 15 number knife, and using this 2 dural forceps, you can expand it and put the tagging sutures. Now you can see, I'm just pausing this. You are already seeing the tumor because this tumor is doing some discoloration, and probably you know where the tumor is, but still you should always use the midline. I'm using the number 15 number knife so that there is minimum damage to the normal cord tissue. Actually, just on opening the arachnoid, there is tumor and some syrinx or some fluid which is coming out. then you extend it, and we are not using coagulation anywhere. And you can see that it is equidistant from both the root entry zone, which we initially discussed. And it's a long segment tumor, so you have to do it almost the myelotomy way below as well, wherever there is tumor. Use minimum coagulation. Then the next step is taking these pile stitches to keep this myelotomy open, because I usually do it with 6-Proli and tag it to the dural inner surface of the dura. So this is how it is done. Now the tumor is entirely in your view. You can use QSA at low setting to start debulking. And this yellow is the tumor. And once you come ventrally, you will get to understand the difference between the tumor and the normal cord tissue. So the spile stitch help you to go laterally as well, close to the posterior column. And basically it's all under vision now. Whatever is tumor has to be removed. You can see a difference of some difference in the tissue texture in the lower pole. This is again tumor, so you can remove it, but extremely careful ventrally. Now you can see at the upper end, it seems that there is some difference in color. So that is actually the ventral surface of the cord in which there may be corticospinal tract. So you need to be extremely careful here. Do not aggressively remove here, or if there is plane, just use that plane. Now there is a thin layer which is left, and the ventral surface of the cord ventrally. You understand? So I think you can peel off this layer with gentle traction. Don't, because using QSA at low setting can be done, but if it's an ependymoma, it will come off. There is a good plane bit from the ventral cord. Again, use a sharp dissection and a flat dissector to remove some residual, like you're seeing this. There is some residual, but you have to be extremely careful and use QSA at low setting, find a plane using that dissector. And always work on the tumor and not on the normal cord. You should work, dissection should be on the tumor rather than trying to separate the cord from the tumor. So this is the last bit probably in the middle part. The ventrally there is a definite difference of the cord tissue and the plane also, you can see. Yeah, so this is how it is done. Now a small Surgicel can be kept within the cavity rather than coagulating every bit of RBC. You can do that. I prefer to restore the cord by removing the spile stitches and taking another stitch to reform the cord as it was, because some people, especially in astrocytomas, people keep this myelotomy open and even the dura open. I think that causes that may not be needed and can be counterproductive, because then the cord gets tethered to the posterior aspect. So then the patient can develop further problems. So better to restore it as it was, what the God made it, in the same fashion, and use this spile stitches once again to suture it back, the pia first and then the dura in the standard way, and then the laminoplasty using mini plates and screws as is the standard practice to do. use Valsalva at the end of the closure to ensure that it is done well and it's watertight, so no leak. There's a long segment dural closure. So this is how it is done. If there is, you do not have neuromonitoring and it's an astrocytoma, very poor plane, it's better to leave a layer of tumor ventrally towards the corticospinal tract, because otherwise patient can develop permanent deficit. One video, the same technique is followed for all intramedullary tumors, be it astrocytoma or ependymoma. The hemangioblastomas are a bit different because you cannot debulk them. This is a small video on hemangioblastoma. This is a cervicomedullary junction. So we also did a suboccipital craniotomy along with a C1 laminectomy or C1, C2 laminectomy, I suppose. And you are doing the same standard posterior midline approach and opening the dura, the lower end, and a V at towards the cerebellum. And you will now see the tumor, because it is a subpial tumor. It's not intramedullary. It will always project subpially. And now it's actually like an AVM. It's just a bag filled with blood, with supply from the vessels. So I'm just trying to open the paya in and around and trying to find out its extent as well as the supply. So very fine dissection. And if you enter this tumor, then there is likelihood of a lot of bleeding even with this small tumor. It won't stop by your coagulation. So you have to shrink it by circumferential coagulation, and gradually these are all feeders which you have to gradually dissect and coagulate. And at times you can check using this temporary clip whether it's a feeder or a venous drainage, like you do in AVM, because again, using if it shrinks on applying your clip, then it's an artery which can be taken. If it gets engorged, it's like AVM, then it's a vein which should be taken in last. So this small tumor has to be given utmost respect. Otherwise, you can have torrential bleeding, and this is not a location in which you can be doing any problem here can have disastrous consequences. So as you can see, we have almost isolated it, and it has shrunk also because its blood supply is gone. And the last bit is probably its venous drainage, which is coagulated and cut. And this is how it is done. And again, the same way. Here, since we haven't done myelotomy, there is no need to suture it back. It is just hemostasis using a Surgicel and a standard dural closure. So, however, at times they can be pretty big. So as I have shown you, I'll show you the intraop picture, how it has to be done. So can you see? This is actually the same tumor which I have shown you, the big tumor of hemangioblastoma, this one. And this is done again at the C1, C4 location, but we haven't entered the tumor. We are doing all circumferential dissection, and this is a big ball of blood, and you can see the cord interface and the tumor. And this patient did well. This was an adult patient, but just to tell you in perspective that it has to be very much carefully done, hemangioblastoma. So we conclude, the conclusion is the intramedullary spinal cord tumor is technically challenging, at times humbling surgery. I mean to say, you've gone with a patient who has minimal symptoms, and you come out with dense deficit. That can happen in intramedullary spinal cord tumor, but obviously with good surgical technique, it's you can have good results. What is usually said is the preoperative neurological status is the most important determinant of the outcome in spinal cord, intramedullary spinal cord tumor surgery. What is meant by that is, if a person is coming with a 4+/5 power, he has a better chance of recovery compared to a person who is coming with 2/5 power. So pre-op neurological status. So if you identify the patient early, you should operate early, rather than saying that no, you do not have much complaints now, you can wait. So waiting, and if it deteriorates, then his chances of recovery decreases. And all these are benign tumor. So the patient is unlikely to die because of that, but they can have significant morbidity if you do not operate. The one other point which is said is usually 1 grade power deterioration following intramedullary spinal cord surgery is usually the norm, because you are handling the cord. So at times, immediately, there can be 1 grade power deterioration, but which usually recovers within 6 weeks to 12 weeks. So you need not worry that if the patient from 4+/5 has become 3/5, probably he will recover. If he becomes 0/5, then probably there is something which is wrong. But 1 grade power deterioration is usually happens, and there should be a reasonable balance between long-term tumor control and functional preservation. So in astrocytomas, if there is no plane, again, functional preservation is more important. Use of appropriate surgical technique, we discuss everything, midline, how to find the plane, or no coagulation or minimum coagulation, CUSA, everything, no transmitted damage by vigorous dissection or something. So it has to be all gentle, proper myelotomy, identifying the tumor cord interface, careful use of the bipolar forceps. Monitoring is advisable. It is slowly becoming the standard of care, which Dr. Harsh will elaborate in the next talk. And good outcome if the pre-op neurological grade is good, because that is the most important determinant, and if you follow the appropriate surgical technique. Thank you so much for your kind attention.
Thank you, Sachin. That was a very good overview of the surgical steps and nuances for those who got interested. And I think we'll take the questions toward the end, depending on the time. Now, and next is Harsh. Will be Dr. Harsh Deora from his associate professor at NIMHANS will be talking on the perioperative aspects of intramedullary tumors and the specifically the intraop neuro monitoring. Harsh, you
Sir.
can take up. Yeah.
Yes,
Go
sir.
ahead.
I hope the
Go ahead.
PPT is visible, sir.
Yeah. Go ahead. No problem.
So I have divided my talk into 3 main parts. First is the perioperative and post-operative management. One surgical video which will describe the neuromonitoring, and then neuromonitoring in greater detail so that you have more idea regarding that. So some of the images and slides might be borrowed. I don't have any financial or intellectual disclosures, and one of the videos has a patient photograph for which appropriate consent has been taken. So just to revise and brush up over our epidemiology and pathology in children specifically, this epidemiological data is up to 18 years only. The intramedullary spinal tumors most commonly are either pilocytic astrocytomas or ependymoma. These are the most common tumors that you will find. Apart from these, low-grade gliomas such as gangliogliomas may also be found. And what is more important for the audience listening, because as I understand, the talk is completely directed towards residents, there are a lot of high-grade glioblastomas which may also be found in this population. As sir told, this is a very important slide, and each line is an extremely important thing. Glioblastomas, which are majority of the tumors which you will deal with during your training, comprise only 5% of spinal lesions actually. This is because you have to understand the spinal cord has less glial cells. Since the cells itself are not there, glioblastomas are less as compared to the cerebral cortex. And ependymoma, which comprise only 3% of intracranial tumors, actually comprise 60 to 80% of spinal gliomas. And ependymomas may be extramedullary, which will be myxopapillary, as I will tell you, and maybe intramedullary, in which cervical are more common than thoracic. Astrocytomas, 50% are pilocytic, 50% of them are infiltrative, of which 1/3 will be very high-grade tumors. So this is just to overview that the new 2021 classification, it is not new actually, now 3 years over. So this is the new classification, so to say, which is subependymoma, ZFTA positive, YAP1. Posterior fossa is divided into type A and type B, type A being the worst prognosis one. And spinal is just divided as spinal subependymoma. Myxopapillary ependymoma, the grade was changed from 1 to 2 notably. And spinal ependymos, which may be grade 2 or grade 3. And a new entity has been introduced, which is called as MYCN amplified. This entity has a high-grade histopathological feature. So if your ependymoma comes as MYCN positive, you have to be extremely careful that it may have early metastasis with dissemination. And hence, the entire neuroaxis has to be imaged at every follower. And all of the cases that have been reported till date have relapsed despite standard treatment in this specific class. Just to revise, myxopapillary ependymomas is grade 2. Again, complete brain and spine neuroaxis MRI has to be done. In uncapsulated and subtotally resected tumors, postoperative RT is warranted. Higher doses obviously will be more effective than lower doses of RT, but with the corollary that more myelopathy, more risk of injury is there. And risk factors include young age and subtotal resection. Astrocytomas are divided into pilocytic and diffuse. In the largest series, which had 136 patients, which was reported from Mayo Clinic, the median age was 35 years, and GTR was only possible in 16% of the cases. Rest of them had a lesser amount of resections done. More importantly, there was no effect in the extent of resection leading to the overall survival. There was no effect on the overall survival. And better prognosis are in low-grade tumors. Tumor location other than cervical, obviously because cervical will lead to a poorer prognosis, extent of tumor involvement along the spinal cord, and greater duration of symptoms. Does not demonstrate, again I repeat, does not demonstrate an advantage for more aggressive surgical resection. This is only for astrocytomas, so this may be an important thing to understand. And postoperative RT will not affect the outcome in pilocytic astrocytomas, and it will change the outcome in infiltrative astrocytomas. Why I'm emphasizing on this, because you will find many people giving a postoperative RT for pilocytic astrocytomas which have been subtotally resected. This will not affect the outcome and only cause more damage than good. So molecular testing is different from cranial tumors. IDH mutations are very, very rare in spine tumors as compared to cranial tumors. Histone K27 and BRAF is very important because, as you may have read the new NEJM paper, Veriumafinib is a new drug which has come for low-grade gliomas and will be effective for all BRAF variants and fusions present. And MGMT promoter methylation studies have to be done for spinal glioblastomas also. Why I'm reiterating this is because it's completely different from what we learn for cranial tumors, and hence you have to understand this differently. This is because if it is MGMT promoter methylated, a reasonable method may be to give temozolomide along with RT, and especially if it is MGMT methylated, and this may lead to a better survival. Just as a glance, these are the various molecular testings that you need to know: IDH1, 2, MGMT promoter, 1P19Q, ATRX. There are certain important molecular tests which you need to understand. That is TERT promoter mutation. If it is positive, it establishes the diagnosis of glioblastoma independent of histology. Even if the histology does not say it is a glioblastoma, if you have a TERT promoter, it is a glioblastoma. Same is the case for EGFR mutations and CDKN2AB deletion. These three are extremely important because this will completely change the diagnosis. There are two important molecular markers that you need to understand, BRAF and NTRK, because there are specific drugs available for them. The BRAF drugs are actually available in India also. So BRAF antagonists and NTRK fusion antagonists are available. These are two things that you need to get done in most of these cases, because this will have a bearing on the treatment. So radiology is very difficult to for most people in spinal tumors. I have tried to make a flowchart for this. There are basically three types of enhancement that are seen. One is nodular or mass-like enhancement, one is patchy enhancement, and one is no enhancement. They can be further divided into margins, that is well-defined margins, central enhancement with shaggy margins, and central non-enhancement with shaggy margins. As you can understand, astrocytomas and ependymoma are the two main tumors which we'll be focusing on. Hemangioblastomas and gangliogliomas, other tumors are quite easy to differentiate as compared to this. However, the main confusion usually arises between astrocytomas and ependymomas. One of the clinchers of diagnosis in ependymomas, most of the cases, if there is calcification and polar cysts, as I will show you in my case example, polar cysts will usually be present. If any residents are there, this is a type A, 1A with a nodular enhancement, very clear margins. This is a type A, again with well clear margins. However, the diagnosis is completely different. This turned out to be pilocytic astrocytoma, and this turned out to be a diffuse midline glioma, H3K27M mutated. This is a type B with shaggy margins. This is a central enhancement is present with shaggy margins. This turned out to be a pilocytic astrocytoma, and this turned out to be a diffuse midline glioma. This is type 2. As you can tell previously, type 2 are the ones which have patchy enhancement, and type 3 which are the ones which have no enhancement. So type 2 patchy enhancement present all along the neuroaxis, with central non-enhancement also present. This turned out to be a pilocytic astrocytoma, and this turned out to be a high-grade glioma, as you can guess by the amount of metastasis that it already has along the neuroaxis. The one without any enhancement can also be a pilocytic astrocytoma. The giveaway to the diagnosis is the cyst with a non-enhancing mural nodule being present here. Again, the differentiation is always between an astrocytoma and ependymoma. This is a well-defined tumor. Contrast enhancing solid component is present, centrally located on axial, multiple cysts, as I already told you, and hemosiderin deposit is present. This turned out to be an ependymoma. Well-defined margins, however, as if you see in axial, it is eccentrically located as compared to the previous one, turned out to be pilocytic astrocytoma. Ill-defined margins, T1 hyperintense signal, excessive edema being present, leptomeningeal enhancement present, high-grade glioma, as you can probably guess. DWI imaging shows enhancement which reverses on ADC. This is a very, very specific feature of ependymoma. If, as sir was saying previously, the tumor outcome completely depends on the grade that the patient has presented in. So there is a specific grading that you can use. You can use the MJOA classification. There are many gradings present, but usually for intramedullary tumors, this is the McCormick's grade of which is used, in which grade 1 to 4 is sequentially worse. If patients have come at grade 1, 95% of the patients will actually remain unchanged. If they have come at grade 2, 7% will improve and 86% will remain unchanged. In grade 3, 28% will improve and 53% will remain unchanged. And as sir told, in grade 4, almost none of the patients apart from one kid, this is a pediatric specific presentation, so I'm just concentrating on that. Only one kid actually improved in grade 4, which was completely dependent preoperatively. Now, how do you manage these patients immediately post-operatively? If you are unsure about the midline, or if you have gone straight away from the midline, most of these patients will have diffuse or permanent paresthesias present, and these paresthesias will not improve. Even if you give pharmacological treatment for them, very unlikely these paresthesias will improve. These are the complaints that the patients will keep on coming in. Sphincter disturbances and sexual difficulties will improve post-operatively. Sensory deficit will stabilize after the third post-operative month, and motor power may continue to improve till 1 year. So if you are doing excessive laminectomies, especially in pediatric cases, there are certain important things that you need to adhere with. If there is a presence of a preoperative spinal deformity, please avoid laminectomies being present. If you have used more than 6 vertebrae, especially if you are including C2, then laminectomies are to be avoided. If it is malignant neoplasm and adjunctive radiotherapy is being planned, laminectomy is to be avoided. This is a very important slide which I found while researching for this topic. I had read, as was suggested to me previously, Schmid and Schmidek, both the editions for this topic. You can see that the status of adjuvant therapy is defined by this one line, which the same editor has used in both the editions. When complete tumor removal, and I'll read it verbatim, when complete tumor removal during the initial operation has not been accomplished, owing to the timidity or caution on the part of the surgeon, we recommend performing a second operation to attempt a total resection. To use, you can understand the status of adjuvant therapy in spinal tumors by this one line. This was later changed, perhaps, by just changing the wordings a little bit. When complete tumor removal during the initial operation has not been performed, owing to caution, the word timidity was removed, we recommend performing a second operation to attempt total resection. This shows that for a surgeon, an intraoperative in intramedullary tumor means surgery, surgery, surgery. Adjuvant therapy has little to no role in it. However, that said, there are a number of trials which are found. Most of these trials borrow from either posterior fossa ependymomas, cranial ependymomas, and which have metastatized or are using the same treatment algorithms for the same. So they have shown that if the child is more than 1 year of age, postoperative radiotherapy is the standard of care, and the local references or the local recurrences is the prominent site of failure, and currently the margin has shrinked to 0.5 centimeters around the tumor. Now, is there a role of chemotherapy? So there is a role of chemotherapy in these cases, especially for children less than 1 year of age, and for some cases where the tumor is very large in size, in which focal RT plus maintenance chemotherapy can be given. Subtotal resection for some high-risk patients can be attempted, in which a short course of chemotherapy is given, and a second look surgery, if eligible, is done, followed by conformal radiotherapy for these cases. This is also, again, pediatric specific that I'm talking about. If the child is less than 1 year of age, adjuvant chemotherapy has to be given, which acts as a bridge to delay the adjuvant radiotherapy at one point of time. There have been no randomized trials for this specific recommendation. However, there are 3 major series which had 41 patients, 73 patients, and 89 patients, of which 6, 36, and 42% never received RT due to the extremely effective chemotherapy that was given to these children. Hence, these children may not actually need radiotherapy and can be avoided, which has an extremely deleterious effect in children less than 1 year of age. If patient has a diffuse leptomeningeal disease, as I had shown previously, craniospinal radiation is warranted. As I told previously, astrocytomas, postoperative RT is not effective in pilocytic astrocytomas, and it is effective in infiltrative glioblastomas. For the residents who are in training, the take-home message for this is that it is reasonable to use temozolomide in combination with RT, particularly if the tumor is MGMT methylated. Now, this is a very specific tumor that we had reported. There have been approximately 35 to 40 cases reported from 2000. This is spinal ganglioglioma, which is a part of the low-grade glioma group of spinal tumors. What I wanted to emphasize here is that BRAF mutant expression is present in these tumors. And as I told you previously, there is a specific drug, virafenib, which has come for this specific tumor. So you can actually get away with not resecting too much of these tumors, because these patients will survive for a very long time. This is a very slow growing tumor, and postoperative chemotherapy can be given in this. Just as an example, I would share one of the videos emphasizing the tumor removal and monitoring that was used in this case. As sir told in the previous talk, that we should avoid the use of coagulation in these tumors. This was the case of a cervical ependymoma. I'm using a tumor which was extending from C3 to C6 with polar cyst being present. As you can see that the location is extremely central to the cord. The electrodes, SSCP, MEP electrodes, are to be placed preoperatively before turning the case. These are C3 dash and C4 dash. This is a FZ electrode that is being placed. I will tell you the classification regarding this. This is using the international 1020 system, which is used. for placing the electrode. Patient is to be placed. I usually use pins because I had one bad complication of visual loss using this thing, horseshoes. So, and I always use pins now. Once the laminectomy, laminoplasty, whatever you want to do has been done, you use a D-wave electrode which is placed caudally towards the lesion. This D-wave electrode can be used to measure impulses when stimulating from the cortex, or the D-wave itself can be stimulated and checked towards the cortex also. You have to be very careful while placing this D-wave electrode so that it does not go into one of the recesses of the dura and then gives a false negative reading. As I told you, open the dura in the midline using the pile dural stitches or hitches being done. There are various ways to identify the midline also apart from the anatomical aspect. This is called as dorsal column mapping, which I will discuss later. Pre-decompression USG is possible to be done. This is the large tumor. As you can see, the cord is only this much anteriorly. This is the end of the tumor. You can see very nicely defined by USG. So as I told, you can check the dorsal root entry zones of the tumors, and this becomes the midline. You use a blade, small blade, to open the alotomy in the midline. Start decompressing. Work on the tumor as sir told, rather than on the cord. You will start finding the tumor as a discoloration completely central in the tumor. Pile stitches obviously can be taken. They help a lot by increasing the volume available for dissection. If you are doing ependymomas, the dissection is usually very, very good. The margins are absolutely pristine. You have to be extremely gentle with the cord. As you can see, I'm using the micro dissector here. Extremely gentle with the cord, not to damage anything, because the margins of the cord will cause those paresthesias that I explained. The cord usually, or the tumor usually, falls away from the cord. Retraction, as you can see, is always on the tumor rather than the cord. Start going towards one pole of the tumor. Dissection is done with microdissectors. No coagulation at any point of time. Once you start lifting the tumor, you can find the attachment, because ependymos will arise from the central canal where the ependymal cells lie. Hence, the ependymal cells have to be divided. You can start rolling the tumor, dissect the tumor. I have started pushing the tumor down now. Completely dissecting. Lower pole dissection is also done. Last bit of tumor remaining. Completely delivered in one go. No coagulation used at any point of time. No CUSA, nothing. Completely en bloc removal is done. This is the tumor available post-operatively. Cord pulsation is well. I do not close the PAEA, but that is completely up to you. You can definitely close the PAEA. There is no hard and fast rule against it. This is the you can see the cord has expanded so well. Preoperatively, the cord was so thin. Now, this is the point where I wanted to emphasize on this. These are the MEP traces that were done. The amplitude had slightly dropped by 77%, 86%. But as I will get to later, this drop is not significant in MEPs or SSCP. SSCPs did not change at all. This is D wave, which we had used. The D wave usually is important. When it drops by 20%, you alert the surgeon, and by 50%, you stop the procedure, because that means that irreversible damage has happened. D wave is, by the way, the gold standard for any intramedullary tumor. You can replace the dura on the lamina, and complete resection has been done. The cord expands beautifully in these cases. This was the patient pre-operatively, completely quadriplegic. This is the patient post-operatively. Even the small muscle wasting of the hands had improved. So excellent outcome for this specific case. Now, coming to the most important aspect, that is the intraoperative monitoring, for which the entire idea has been brought out. Just for the residents, this is the general outlay for the tracks. You have to understand lateral corticospinal tracts and ventral corticospinal tracts both will contribute towards the motor. It is just not ventral. And the ascending fibers are the dorsal columns. Usually for the spinal cord, SSCP, MEPs, and triggered EMGs are done. The other evoked potential monitorings are done for other cases. Mechanism of injuries can range from either mechanical disruption, thermal injury, which we will try to avoid, pressure injury, or it may be related to hypoperfusion, either anemia, hypotension, hypothermia, hypoxia. Multimodality monitoring is what we need in most of these cases. So for sensory, what we'll do is SSCPs. For motor, we will do MEPs. These are the type of electrodes that you use. This is the setup. Mostly corkscrew electrodes are used for stimulation, and for recording, bipolar electrodes are used. IONM has certain risks with it. MEPs are usually not continuous. They are done when you ask the neurophysiologist to get an MEP done, but this may cause certain movement in the patient, especially if the patient has a tongue bite in, for example, in ICU patients, or if the surgeon, if the anesthetist put a tongue bite, you have to be very careful regarding the injury. Current is high, the patient will move. You have to be very careful about that. It can even cause seizures. Specifically in pediatric cases, the risk is even higher. If you are placing electrodes, be very careful regarding the arterial line, the ET tube. These all should not come in the way after positioning. The anesthetist should not have problem regarding this. There is a very important thing that the success of IONM completely and totally depends on the communication between the surgeon, the anesthetist, and the neurophysiologist. You cannot have miscommunication or loss of communication between the three. The success completely depends on that. Evoke potential basically means that you give a stimulation, there is a certain latency, then the amplitude of the current will rise and fall, and you check it over the time that has happened. For SSCPs, either you use the median or the ulnar nerves for the upper limb and the posterior tibial nerve for the lower limb. Bipolar stimulation is used. If you want to know the amplitude, usually starts from 20 to 40 milliamperes. The C3 dash and C4 dash and FZ are the electrodes that are needed just behind the motor cortex, which are placed for recording. There is a signal filtering which happens, which causes a significant delay in this receiving, because there is almost a 16-minute delay from the from the time that the injury has happened to the time that you will actually receive it on the SSCP. So 16 minutes is a significant amount of time. The advantage of SSCP is that this is a completely continuous monitoring which happens, so you need not do it again and again. It is continuous, and it is very, very specific towards a dorsal column. If there is a drop in SSCP, then dorsal column has been injured. So there are various points at which you can check the SSCP, the various waves which are formed. The most important wave for the residents is the N20 wave, which is the somatosensory cortex at the scalp. There are various other points where you can find the various waves and check it. But for general idea, the wave is N20 for the somatosensory cortex. A 50% reduction in amplitude and or a 10% increase in latency is the warning sign. The amplitude reduction is more important rather than the latency. There are various advantages. As I told you, it is continuous, very specific, less confounded by sedation or hypothermia. And there is a need to rule out any other injuries or electrical interference which may happen in SSCPs. Coming to motor evoked potentials, the stimulation, the receiving was at C3 dash and C4 dash for that. Here the stimulation is at C3 and C4, and the receiving is at the lower limbs or the upper limbs. Specific muscles can be checked, and it will induce movements, and it has to be checked at specific points of time. There were various warning signs that were described for these cases. As I told, SSCP was previously. MEP, when the first time it was described as an all or none phenomena. If you have an MEP signal coming, it is all okay. If you don't have it, there has been some injury. Then there was a change by reduction by 80% amplitude. Again, it was revised to 75%, and now it has been finally settled on a reduction of 50% amplitude. There is a second criteria which has come into picture by Candice et al., which is a threshold increase of more than 100 volts for eliciting response. So for the residents, the final answer remains a 50% reduction or a more than 100% volt increase in stimulation should alert the surgeon that injury has happened. So what are the goals while doing an intramedullary tumor surgery with neuromonitoring? It is to maximize tumor resection at the minimum point of morbidity being present. So factors to be considered, especially in a country like ours, are availability and cost effectiveness, ease of utilization, ability to identify, and whether it changes the decision making or not. So cost effectiveness has to be balanced against the amount of complications that have happened. Hence, it is definitely cost effective because the amount of complications that you will prevent is extremely high, and then hence protends towards this cost activity. There are three people which are mostly needed in this: the neurophysiologist, the neuroanesthetist, and the neurosurgeon. Implementation and interpretation is by the neurosurgeon and the neuroanesthetist, and the setup is done by the neurophysiologist. Once you identify the neural injury, that is either a reduction in 50% amplitude, it is very, very indicative in these cases, or an MEP or SSCP together done would be better than either one of the modalities completely used. Coming towards pediatric specific ideas, there are certain three key points which you need to understand. One is that the corticospinal tract will only be myelinated at 3 years of age. So if you are operating a case which is less than 3 years of age, probably the signal may not be as good, or you may not be able to completely rely on what you are hearing there. Secondly is most of these tumors will grow rostrocaudally, that is from up to down, and hence the recording the upper limbs becomes more important than the lower limbs. There is a definite plasticity in the pediatric spinal cord. Hence, even if you find a malignant lesion or a lesion which is difficult to resect and you have found certain injury there, it would be prudent to be more aggressive in pediatric cases because plasticity is still present, and hence they may mostly recover. In the largest series that I found of 130 pediatric cases, this monitoring technique has an unquestionable favorable impact on the neurological outcome. Changes in SSCP, transcranial and SSCP improved the amount of resection and safety of tumor resection. It actually encourages more aggressive tumor resection because the surgeon becomes extremely sure of what he is doing and hence can be more aggressive in these cases. IUNM is usually divided into two parts, that is monitoring and mapping. As I discussed previously, SSCP and MEPs are the monitoring aspects. There are two more monitoring aspects which can be used in intramedullary tumors, that is the D-wave, which I will come to now, and the free run EMG, which is used for most intradural extramedullary cases and intramedullary cases. Some new modalities which have come, which will be very important in the years now, is the dorsal column mapping, which is used for finding out the midline myelotomy very, very specifically. Intramedullary motor mapping has been introduced, which can find out the corticospinal tracts like we found out the motor cortex in cranium. And triggered EMG is also one more thing where you can actually identify the various nuclei in the spinal cord also. So warning criteria, just for revision, remains the same. If you use SSCP and MEPs, the positive predictive value goes up to 86% as compared to only using one of them specifically for these cases. MEP, again, warning criteria remains the same, but presence or absence of waveform is the final idea that you should have during this monitoring. Specificity is very high if you use both of them. Coming to D-wave, which is the most important, the induction or the stimulation is given at the C3 and C4 above, and the direct measure, D-wave means direct wave, is checked by the alpha motor neuron fibers, fast conducting fibers at the dural level. It is, however, as you can understand, limited to where the cord exists, that is T10 to T11. It is a single pulse stimulation. No roots or cauda equina can be done in these cases. One basic advantage of D-wave is it is not affected by blood pressure, heart rate, temperature, or anesthetic drugs. So it can be used in any and all cases, and hence remains the gold standard for intramedullary tumors. If a reduction by 20%, surgeon has to be alerted. Reduction by 50%, you need to stop the procedure there and then, and hence D-wave has become the standard of care for any intramedullary resection at this point of time. Free run EMG can be done for most of these cases. It is, however, more used in tethered cause, intramedullary, intradural extramedullary regions, screw insertions, or root decompressions. Irregular periodic bursts when you are manipulating the tumor, or more than 3 second bursts in the tumor, or acute drop-in signal in one of the nerve roots should alert the surgeon that free run EMG has caused injury there. Coming to the more important aspect which is coming up now is the dorsal column mapping and motor mapping. The dorsal column mapping is used for predicting where the posterior myelotomy is to be done. Now, you have to understand, like the brain, where there is a change in the motor strip to the sensory strip, there is a change in between the left and the right in the midline myelotomy. And this change between left and right can be used to find out where the midline lies. So what we do is that we place an electrode on the postoperative posterior aspect. I'll show you. This is the electrode which you place, which has 8 specific points of stimulation present. Now you stimulate at this point and check at the cortical level. This is the electrode being placed. Check at the cortical level, and a change in the waveform from upper to lower. That is where the trough is arising and where the nadir is arising. Tells you where the myelotomy is to be done. For example, between 4 and 5 here, there is a change here. As you can see, there is a downward slope here and there is an upward slope here between the 4th and the 5th, and hence the myelotomy or the midline lies between 4 and 5 here. There is no need to do it anatomically. You can actually get it completely done electrophysiologically. As you can see, the electrode is placed here. Between 4 and 5 is where the myelotomy is to be done. It can also be done using the veins, as sir told, but this is a much more safer method to be done here. Electrode placed here, again this is to be done. Again, one more another aspect is you can use a bipolar stimulator and stimulate on one side and stimulate on the other side, and you will find that there is a change in the waveform, that is trough forms here and a peak forms here, and in between the two you can do the myelotomy specifically. This is especially useful if the tumor is very eccentrically located, because if this tumor is eccentrically located, you don't know where the midline is. And so the point where you need to do the myelotomy changes completely. The dorsal root entry zones or the vein may be completely distorted in some cases, especially in recurrent cases. And hence the myelotomy in these cases will be very nicely done. Now, this is a very important new modality which is coming in, not exactly new, but it has come in a larger aspect now, where you can use a bipolar probe to actually stimulate the corticospinal tract anteriorly. So what this will use is that you use a 5 mm probe, a monophasic square wave pulses are given, which is less than 10 milliampere, and you will find out the motor cortex being stimulated at the lower muscle where the electrode has been placed. And up to 5 mm is the distance at which you can do the motor mapping in these cases. Another important method which has come is the D-wave collision technique. What you do in this is that you do a trans-electrical stimulation at the motor cortex above, and you do a D-wave stimulation at the spinal cord. Now, if you are at the motor cortex, the D wave amplitude will be much more as compared to the transcranial, because you are not at the motor cortex at transcranial. It is going through the cranium and then this wave is arising. Whereas in the D wave, if you are on the motor cortex, that means you have gone inside the cord and you are on the corticospinal tract, the amplitude will be much higher. So once the collision between the waves happens, if the collision leads to a zero amplitude, like in this case, that means you are nowhere near the corticospinal tract. However, if the collision leads to a positive wave, that is the D2 wave, that is the wave that you had stimulated at the spinal cortex is higher, that means you are exactly at the corticospinal tract and you need not go any anterior. This is such a specific medicine method that you can actually localize the corticospinal tract to within 1 mm, which is the most specific that I have till date read in any of the cortical mapping techniques. So these are some of the examples of the papers that were previously done. You use a bipolar stimulating probe to check out the corticospinal tract here, and you can actually go on and check out the thenar, hypothenar, all the corticospinal muscles can be stimulated in this, and you can actually check specific muscles for these specific tracts and tailor your resection according to this. However, at the end of the day, as I understand, surgeons' discretion is the best that you can have. These are some of the examples in which intraoperative neuromonitoring was used in various pediatric and intramedullary cases. And this only tells us that intramedullary tumors need neuromonitoring without any doubt. Once there has been a signal change which has happened, there are certain things or specific checklists that you need to follow. This checklist I will be sharing shortly. First and foremost thing is you need to stop whatever you are doing. You need to rule out the technical issues. Is there any change in impedance, recording, stimulation? Is there any change in physiological parameters? Irrigate the area with warm saline, increase the blood pressure, use papaverine. Just as a case example, this was one of the cases where MEP was lost. So this was a cervical intramedullary tumor. For the residents who are listening, you stop the procedure first immediately. You reverse whatever last step that you had done. For example, you were dissecting on the anterior part of the cord, you stop dissecting there. You increase the mean arterial BP to more than 85 mmHg. check whether the patient has hypothermia or not. You wait for 20 minutes. If the spine is unstable, you continue with stabilizing the spine first. And if the patient, however, if the spine is stable and the patient is possible, you have possible to wake up the patient, then you wake up the patient and check whether the damage has actually happened or not. This is the checklist which I was talking about. If there has been a change in neuromonitoring, and I can share this checklist to anyone who wants it, there are specific things that the spine surgeon, the neurophysiologist, the anesthesiologist has to do. This has to be followed in a specific pattern, mostly includes what we were saying. And once this is done, either you increase the MEP, you give steroids, you consider a wake-up test, consider aborting surgery, or consider giving a CCB drug to be done. You need to be very conversant about what anesthesia is being given. A short neuromuscular blockade has to be avoided at all points of time. Any ischemia due to low blood pressure has to be avoided. You need to be in clear communication with the anesthetist that if there is a hematocrit which has fallen, if there is too much of blood loss, hypothermia which has happened, these needs to be reversed. Any hypoxia which has happened may need to be reversed in all these cases. Check whether there is any hypo or hypercapnia. If there is a PCO2 which has increased to more than 50 mmHg, then needs to be reversed. If there is any hypothermia which has happened, that is the core temperature has fallen more than 2 degrees from the previous baseline temperature, then it needs to be reversed. If there has been a vascular or neurological compromise, if you have positioned the patient wrong, or if there is too much of neck flexion or extension, then these needs to be reversed. Once this is done, this is a general overview of all the monitoring that has been done. SSCP, MEPs, and direct waves are what you need to basically understand. A 50% reduction in amplitude, 10% increase in latency, more than 100 volts pressure that needs to be increased, and a 50% reduction in amplitude by direct wave is important. Direct intraoperative monitoring is the standard of care now. There is no doubt about that. There is diagnosing injury before it becomes irreversible is the goal, and understanding the principles of locating the injury, clear communication and reversal is what is important. And at the end, just one line: a fool with a tool still remains a fool if you cannot utilize the tool perfectly. Hence, intraoperative monitoring is here to stay, and you need to understand it very, very clearly. Thank you so much for your patience. I hope I didn't exceed the time limit too much.
Thank you, Harsh. That was extensive and detailed aspect of the IONM. I think both of you together have covered the surgical aspects very, very in detail. I had few questions for you. I mean, we don't have much time. I don't see much questions in the chat box, but for the sake of completion of the topic, I want a few questions to be answered. One is, both of you did not clarify the use of steroids preoperatively, methylprednisolone preoperatively. Just one comment, not much of a discussion because we don't have time. Quick answers.
So there is no grade 1 evidence.
Agreed.
Of what you are doing steroids for is you are considering.
But there cannot be a grade 1 evidence for such a scenario,
exactly,
isn't it?
So that is one. Second thing is what you are giving steroids is for either, you need to understand that either the steroids is being given for vascular edema or you are giving it as a part of injury of intraoperatively when you are giving it for injury of spinal cord. These are two different aspects.
Agreed.
So one thing is preoperatively for vascular edema, yes, I would be in the favor of giving. Intraoperatively for trauma, as the NIMHANS trials have already told, the amount of dose needed is extremely high, and the amount of complications, diabetes, wound healing that it will cause I probably outweighs the benefits, I would.
Yeah, but it's a short one. Sachin?
Yeah. So I did in intramedullary, I usually start the bolus dose when I do myelectomy.
Yeah, 30 milligram per kg?
Yes. And what I do is I assess the patient post-op. If he's good, I'll stop that and just shift to dexamethasone for 2 or 3 days and stop it. No continuation for 24 hours. So this strategy has worked with me. And I'm reasonably sure that obviously induced trauma because of surgery is taken care of.
Exactly. No, I mean, residents should be aware of such such a discussion happening in this scenario. I think the next issue is, just to add to Harsh's list of diagnosis, intramedullary dermoids and tumefactive demyelinations are a very important mimics and of course entities in children. Tumefactive demyelination is one thing which can critically reflect as a tumor, and you might make a mistake of going in for an extensive workup.
Yes, sir.
So
just to be clear, 1 second, 30 milligram per kg means 2.1 grams for a 70 kg man, or in children it might be lesser.
Yeah, children.
But 2.1 grams is a huge amount to be given at one point of time.
Yeah, children, it's okay.
Children is lesser. So for pediatrics, I understand, but for
dermoid, we see a lot of things, but
yeah,
they are quite clear.
Again, no, I'm just saying that just to add to the whole diagnosis. That's all.
Yes,
and they usually have some midline stigmatas. So stigmatas go along with intramedullary. Something else I would like to add was I use a pediatric craniotomy for the cuts, like the ultrasonic scalpel.
Yes.
So just to complete the dog, I'm not adding to
the
anything.
only thing with using any sort of craniotomy, that the foot plate goes within the canal.
Yes.
And I'm a bit
skeptical
apprehensive of doing already compromised cord, anything. But that is quite thin, the B5 attachment.
But, agreed. So certain things was, for closure of the PAEA, people use liga clips too. You can have a quick closure. And then in the myelotomy, both of you mentioned midline myelotomy, but myelotomy, the DRES entry zone, root
I didn't want to confuse the
no. They should be aware of it, because you have an eccentric tumor like ependymoma, a DRES entry zone is an option. And I think essentially, and of course, I would reiterate that use of neuroanesthesia is a very important part, not only for IONM, keeping the patient normotensive or on the hypertensive aspect, especially when you have a deficit. So neuroanesthesia is a very critical part of tumor surgeries in intramedullary location, isn't it? I mean, earlier it used to be hypertensive anesthesia, which is obsolete now. You need to maintain normotensive or hypertensive at times, isn't it? So that's also
absolutely hypertensive would be actually preferable if you can control the bleeding.
So they have to be very. They need to have a low threshold for adding vasopressors or blood products, of course. And the second thing, one more thing, which
so I think Sachin sir mentioned that somebody some people don't even close the Deora. So this paper was actually from CMC
high grade.
So sir. So they had actually, and they did not observe. Just for completion, they did not observe an increase in CSF leak rates. Despite not closing the Deora.
One more thing which Harsh, I want some clarity. What you mentioned about the suite edition 6 and edition 7 is especially for ependymoma. If a biopsy comes out to be ependymoma, then you go ahead with if you have left a residual,
we need to go ahead.
But
so not for astrocytoma, is
it? So the topic is only the chapter is only. I was extremely shocked when reading this. So the chapter is only intramedullary spinal tumors, and I mean it's very. I don't know. We are recording, so very apprehensive of some person, any author to write timidity of a neurosurgeon. I was very shocked. So what I wanted to convey is that intramedullary tumors are primarily surgical at this point of time, as we stand today. So you need to be. They have not mentioned ependymoma specifically in that line. I can actually share the whole book. They have recommended for astros also. Although I would beg to differ, frankly
speaking. To give a message to the youngsters,
I
think ependymoma, it will be better to go
exactly. So that is why I said that when
astrocytoma, actually you are not able to remove because you couldn't find a plane.
Planes,
And if you go in again, you will probably damage more.
So because the residents would be reading suite, if they read this line and they get confused, that is why I put it specifically that please don't get dissuaded by this line when you're reading suites.
And there's a term cherry picking which is used for ependymomas. When you have even a small tumor left over, because the chemo and radio sensitivity is low for these tumors, you go back and remove it.
Absolutely.
So
Yes.
just and one more. Regarding fixation post laminoplasty, in the youngest ones, even sutures like absorbable sutures like PDS works very well.
Will work.
So
Will work.
yeah. So I was just platelet screws might not be possible for the younger ones. Adolescents and beyond, of course, platelet screws are acceptable.
That's right.
I think, shall we close? I don't see any questions in the chat box. If Naveen is there, Naveen, you want to comment?
I was there. Thank you, Dr. Sachin and Dr. Harsh.
Yeah.
It was a very engaging talk. I think, both of you covered extensively. And I think intraoperative neuromonitoring is becoming an essential part of the surgery here. I think we'll not, but I think if there are no questions, we can safely close the session here.
Agreed. Okay.
Absolutely.
Okay. Harsh and Sachin, thank you very much. Both of you have been extensive and to the point for the sake of residents. I think it was a very valuable session, and the resources. I think towards the end you might put your resources, for the residents to catch up with those resources which are very valuable. Some of them are very valuable, isn't it? Other than the textbooks.
Yes, sir.
That would always be nice if you can do that in the chat box or something, and just can put it copy paste if possible. The next thing is for the residents. These talks are available on the YouTube channel. Please go back if you think you want to revise the thought process and look into the previous talks. Additionally, all the classes happen on the last Sunday of each month, and the next class is going to be on August 25th, and the topic is optic-asthmatic glioma as a part of our neuro-oncology session. I think with that, we'll close this session. Thank you, Harsh. Thank you, Sachin, and from Naveen and me from IndusPN. Thank you. Thank you, everybody, for joining this class. Thank you.
Thank you.
Yeah.
Thank you so much, sir, for your wonderful deliberation and informative content. And thank you for joining the session.
Thank you, Asya, and good night. Good night, everybody.
Good night.
Yeah, thank you.